Good afternoon, everybody. I'd like to welcome you to our session on the socioeconomic impacts of COVID-19 on the health and well-being of First Nations, Inuit, and Métis populations. This is a session that is under the purview of the National Collaborating Center in Indigenous Health in the University of Northern British Columbia. Before we begin our session today, a moment of sadness and remembrance. We in the center and as part of the committee have had the privilege of sharing on the committee with Dr. Tom Dignan, who has just transitioned into the other side in the last couple of days. So we'd like to take a few moments to remember Dr. Tom Dignan, who's been a pioneer in medical health, who has served us as mentor and friend, and who has been an inspiration to people across Canada for the last numbers of years. He has served in many capacities. He was at first the president of the Nurses Association of Canada, and he was also a founding member of the Native Physicians of Canada. He was a very important person in improving the health status in Northern Ontario, serving as a fly-in doctor for many years as well. And he's an inspiration in terms of the journey he went through to acquire his education, going through first joining the Marines, then entering into getting his general education diploma, and therefore from there going on to acquire a nursing degree, becoming a nurse, and then going back into medical school. And so he's been a real inspiration to us, and we are going to miss him as a leader and as a colleague. So I'd like to take just a moment for all of us to have a moment of silence in memory of Dr. Tom Dignan. I'd like to introduce, my colleague, Sarah DeLay, who will introduce herself.
Thanks so much, Dawn. It's such a privilege to work with you, and of course to have worked with Tom for so long as well. I'm with the National Collaborating Indigenous Health, and have worked, of course, with you for more than 15 years, Dawn. So I'll hand it back to you to introduce our elder, and then we'll go through a couple of housekeeping regulations, and we'll get this show on the road. Dawn, thanks so much.
My name is Don Fiddler. I've served as a co-chair of the National Collaborating Center for Indigenous Health for these many years. And I am Métis from Saskatchewan, Métis Cree. My mother and my father, both sides are Métis, and going back many generations, both on all of my grandparents as well. I have been privileged to work with a number of people across the country, and really look forward to this webinar and having us address some of the issues that we know are outstanding with respect to our health disparities, in particular as they relate to this pandemic. I would like now to introduce to you our elder who is going to speak to us. Our elder comes to us from Métis Nation of Ontario, or I'm sorry, Métis Nation of British Columbia, and she will give us a brief prayer. So Elder Barbara Hulme.
Good morning. Thank you for inviting me to join you on your second of 4 virtual conference sessions. Before I begin, I would like to acknowledge that I am speaking to you from the traditional territory of the Lekwungen-speaking people, and whom today we recognize as the Songhees and Esquimalt nations. These are also the lands that the University of Victoria sits on, and where I am the Métis Elder in residence. My name is Barb Hume, and I have been a grateful visitor on these lands for over 25 years. I'm originally from Treaty 1 territory, Selkirk, Manitoba, and many of my family still reside in that area and have resided there for many, many hundreds of years. At this time, I ask the Creator to hear the voices of the people who heard their words with each of us today. And I ask that each of us listen to those words carefully. Some topics may be difficult, but I ask that the truths be recognized and respected, and that we proceed in our actions with humility, honesty, courage, and wisdom, and above all, love. Love for each person in our personal universes, in our country, and beyond. I ask that the wisdom shared and the work being done be recognized and respected. I ask also that the work being done for others has the hoped for results to positively impact the lives of so many. I ask that we hear the words of our ancestors and heed them, asking that others hear these words, also recognizing that all words, all actions are for the future of our people, all of our children. As we keep our children, our future generations in our thoughts, we must also keep our earth, our water, our air, and all things that are part of our land, sea, and air in our thoughts as well. Thank you.
Thank you.
Thank you so much, Elder Hume. And Dawn, thank you again just for facilitating that moment of silence. There's already been some notations by participants that Tom will be extraordinarily missed. Your kind words and over your presentation of what a special person Tom was is pretty amazing. Dawn, it's really a pleasure to be working with you this morning. I'm sorry we can't be together in person. I always appreciate your presence and your wisdoms. I grew up on Haida Gwaii folks, and I divide my time now between the very different geographies in British Columbia, lands overseen and held and cared for by Late Latine, the Decal Nation, and the Silks, or the Okanagan Nation, where I'm joining you from today. It really has been one of my greatest honors to work for over 15 years with the National Collaborating Centre for Indigenous Health. And it's with huge excitement, and thank you for guiding us with your wisdom, Elder Hume, that we are being joined today by 5 amazing panelists. There's a few little changes to the agenda, folks. The first is that our second speaker, Dr. Theresa Tam, does have to leave us shortly after she presents with us. So we'll move directly from Dr. Tam's presentation to a question and answer period. Then we'll move into the next amazing presenter. That will also be followed quite directly with questions and answers. Today's session is being recorded, so for folks who may not have been able to make it live today, don't worry. The recorded session will be posted on the NCCIH website. Couple of other housekeeping things to mention. You're going to see a Q&A bar. You might want to pop that up on your screen, folks who are participating. And you're welcome to have questions inputted there throughout the presentation. Those will be answered as we move along. You'll probably have already noticed there's some brief pauses as we switch between presenters and we move between who's muted and who's on video and who's not. It's a Zoom world, folks, so just be forgiving for any blips and up and down. So we should be able to move through that quite seamlessly. Just a reiteration of what my colleague and friend Dawn has already said. The presentations today will highlight the breadth of socioeconomic and health impacts that the COVID-19 pandemic has had and is having on the lives of Indigenous people in Canada. This is a remarkably important, pressing set of informations that is going out. And I'm truly honored to be with everybody today to think about this incredibly important topic. We do have 5 panelists for this session. The first, the video that will start very momentarily, is going to be presented to you by Dr. Chris Mushquash. It's a video recorded presentation, so it's not live. If you have any questions for Dr. Mushquash, please send those directly to the NCCIH and we'll facilitate getting Dr. Mushquash to answer you, or we'll provide information from him. A little bit about Dr. Mushquash, although he does provide a beautiful introduction of himself. Dr. Mushquash is an Ojibwe member of the Pays Plat First Nation. He's a registered clinical psychologist in Ontario and is a Canada Research Chair in Indigenous mental health and addictions. This is a remarkably pressing and important presentation that he's about to offer. And again, if you do have any questions, please just go ahead and send them directly to the NCCIH team and they will facilitate you receiving answers. Thanks everybody, and please enjoy Dr. Chris's presentation.
Hi, my name is Chris Mushquash. I'm a clinical psychologist by training, but I work as an associate professor in the Department of Psychology at Lakehead University. And then I work with clients at Kudloo Anishinaabe Family Care in Thunder Bay, Ontario. And we are an Indigenous governed organization that's a partnership between 13 First Nations within the Robinson Superior Treaty Area. We provide a range of services. We've got mandates for child welfare, mental health and addiction, and also health. So in that way, I consult and work across a whole range of different services through my role as a psychologist at Toledo. Really pleased to be here with everyone today, even though I'm unfortunately not able to be there for the live broadcast. Thanks for including me in this opportunity. I guess I'm going to say a few words today just about how to try to maintain wellness in the context of the COVID-19 pandemic. I think when the pandemic first began nearly a year ago, there was a lot of uncertainty that people experienced and a lot of distress and anxiety that people experienced as well. And these are all, of course, natural reactions to things that are uncertain. And I think that, for some, there was a bit of a challenge in determining what to do about it and how to find your way through it. And I think that in some ways during the first wave, we kind of, many people sort of tried our very best to wait it out. And what we're learning now is that as the second wave continues, that maybe it's less about waiting it out, but more about learning how to find our way through it in a way that's more adaptive, in a way that promotes wellness. So when I think about how to go about doing that, I guess I come back to what our culture teaches us and what the lessons from the land are when it comes to maintaining wellness. And then I think about, how do we bring that into our lives in a way that is purposeful, that gives our lives purpose each day in a way that promotes hopefulness, and in a way that allows us to belong with others in a way that's safe, and in a way that reduces risk of transmitting the virus, and in a way that provides our lives meaning. So I often talk about the lessons from the land and bringing those into our homes. And what do I mean by that? Well, one of the things that we know about being on the land is that everything that we need to be well exists there in some way. It was placed there for us. And when I think about there are a few ways that you can kind of look at that question. One is from a practical sense. There are the basics, the basic necessities of what we need. So, food and water, and the ability to construct shelter, and if you expand that out, the ability to heal, medicines, the ability to conduct ceremony, and all of those things that make us well. If you sort of move that into the next layer of what we learn from the land as well, it's that it's that being out on the land provides us with a lot of structure. So when you wake up in the morning, there's a lot of things that you need to do, and if you don't do them, then they don't get done. The importance of getting the fire going, getting wood collected, getting your meals organized for the day, doing all those things necessarily imposes a lot of structure in our lives. And in fact, that structure and that those tasks are part of our daily purpose. If you look sort of outside of Indigenous knowledges to sort of mainstream psychological approaches, say cognitive behavioral therapy, one of the active ingredients, if not the active ingredient in cognitive behavioral therapy, of course, is activity scheduling, behavioral activation. So it's making sure that we have things in our day so that we keep ourselves busy with tasks that help us move towards some type of goal, but also give us opportunities for rewarding experiences. So we learn that from the land, and we can bring those lessons into our house, particularly as we move through the second wave of the pandemic in a more purposeful way. How are we going to fill our time? What are we going to wake up and do each day? How are we going to keep ourselves busy? What types of goals are we going to work on? And how do we continue to pursue those in an incremental way? That is in a step-by-step way that eventually moves us to where we want to be. And that could be, a new thing a new skill that we want to develop through the pandemic. I think we saw that during the first wave. I remember news stories about, grocery stores starting to run out of flour because so many people had taken up, baking or cooking, and that was a way of spending time at home to develop a new skill, but also to do something for others. Cooking, feeding other people. And I think that's the next thing that the land teaches us, is that the importance of responsibility. So responsibility of ourselves, but also responsibility for other people. And if you look at the way that many communities have responded to the COVID-19 pandemic, it's been through activating our networks, our relationships, and trying to provide and particularly for those who are most at risk or most vulnerable. So many communities organized ways of bringing groceries and other things for those who were maybe unable to do so because of age or because of physical limitations. Really thinking about what the importance of our teachings around caring for others, and in particular caring for the most vulnerable among us. And that's something that we can continue to do purposefully during the second wave. During the first wave, so many things, so many services and supports shut down, that one of the consequences of that, I guess, was that many of our most vulnerable people were left without necessary supports and services. So, in an effort to stop the spread of the virus, shelters, closed in different places. So, many of our children and women and families who are experiencing domestic violence then lost access to that important service. Many of our addiction treatment centers closed. So those among us who experience addiction-related difficulties, didn't have that service or support available. And we saw more and more of those things kind of, and we began to understand them in a better sense as to, where where the gaps that existed became exacerbated. We now know what those are, and we can pay attention to those during the second wave and beyond as a means of trying to ensure that we continue our responsibility for others, and that's one of the things that also brings us our meaning in our life. The land also structures our days in a very physical way, so we can bring that lesson purposefully into our home and try to ensure that we're doing at least something that's physical each day. The other lesson from the land is that what we eat on the land is generally very, very good for you. Now, food insecurity is a major problem in many of our communities and among many of our people, and I know that that's a big issue that's sometimes very, very hard to contend with. How do you try to be healthy in a context by which what you need to be in a context by which it's very, very difficult to afford those things, or they're not available where we are. But again, I think sometimes when the structure falls out of our days, then our ability to pay attention to our body and our physical needs when it comes to ensuring that we're eating as well as we can eat, and not eating too much as a result of stress or anxiety, and paying close attention to those things is something that we can bring into our home as well. And then sleep. The land teaches us the lesson of sleep. The average the average adult requires somewhere between 7 and 9 hours of sleep a night, and it's quite interesting that generally aligns with our day and night cycle. So when you're on the land, you're going to bed when it gets dark, and you're waking up when the sun begins to come up, and that in and of itself, if you can sustain that for a period of time, your body will be rested, and you'll have your 7 to 9 hours of sleep a day on average. During the pandemic, the stress of it can be very, very difficult to sleep at times, but also the disruption in our lives might mean that we're spending more time on television or more time on social media or other things that serve to disrupt our sleep, which is a very, very foundational part of wellness. So in summary, one of the things that we can begin to do as we learn to navigate our way through the second wave of the pandemic is to think about what those lessons from the land are, and what those lessons from our culture are, and find ways to bring them into our homes, to pay attention to them, and to support other people in terms of making sure that those general wellness needs are being met as best they can as well. So again, I apologize that I'm not there in person, because I'd love to engage and chat more around specific questions and comments that people might have, but those are just some general thoughts that I thought I would share with you today. So Chimigwech again for the opportunity to be a part of this important gathering.
There was incredible wisdom offered to us by Dr. Mushquash. And Dawn, I know you're looking forward to introducing our next speaker.
Yeah. Thank you very much. It's my pleasure to introduce to you Dr. Theresa Tam, who was named Canada's Chief Public Health Officer on June 26, 2017. She's a physician with expertise in immunization, infectious disease, emergency preparedness, and global health. She's also a fellow of the Royal College of Physicians and Surgeons. She has over 55 peer-reviewed journal publications, and she's a graduate of the Canadian Field Epidemiology Program, Dr. Tam.
Hello, everyone. Thank you so much for the National Collaborating Center for Indigenous Health for hosting this great event, and to speak to you a little bit about my report from last year. And thank you, Elder Hume and Dr. Mushquash. I do wish he was here. I learned so much just in the last few minutes. It has been incredible. But before I begin, I'd just like to acknowledge that I am speaking to you from the traditional unceded territory of the Algonquin and Anishinaabe people. I'm really happy to connect with you from the various territories and communities that you are in today. So it's very easy to get caught up with a daily response to the COVID-19 pandemic. So I thought I would use the opportunity of my annual report of last year to focus on the broader aspects of the impact of COVID-19. So this pandemic is a very humbling experience, I think, for all of us who've been working in public health for many years. It is a very powerful example of how much of a serious threat an emerging infectious disease can pose to all of us now, but also in the future, because something like this will happen again. It's jolted, I think, our collective consciousness into recognizing our health really does depend on our social and economic well-being. So, myself and the team who works with me in my office were very fortunate to work with Indigenous leaders at the Canadian Institute for Health Research and Dr. Mashwood Pringle from the University of Toronto in convening two discussions to hear about the impact of COVID-19 for First Nations, Inuit and Métis communities, as well as resilience and innovation during this pandemic. And we do have the What We Heard report, which will be available online shortly. Maybe turn to the next slide. So these reports will be on the Canada.ca website. And so I'll just spend a few minutes just sharing some of the highlights from these reports. Next slide, please. So we've learned so much during the past year, and this very steep learning curve continues. And SARS-CoV-2 is the virus that causes COVID-19. And what we learned was it's spread from person to person through respiratory droplets. And then we learned that more and more about how smaller droplets can linger in the air in some circumstances. So that the virus is most easily transmitted when people are in close contact with each other, particularly whether they have symptoms or not, and that they can be most readily transmitted indoors in crowded conditions. As you can imagine, indoor crowded conditions where people are close together, talking, singing, all these activities happens in everybody's daily lives, particularly if you lived in crowded housing or your job requires you to work in crowded environments. So previous research on epidemics or pandemics, which are global epidemics, shows that the risk disproportionately impacts specific populations. And so we use this framework in the report to capture all of these risks across populations as they are shaped by differences in exposure, in susceptibility of the population, and in access, differential access to healthcare and financial and other assistance, and also impacted by previous discrimination by our healthcare and other systems. So what this framework underscores is that equity matters, not only to those who are unjustly excluded, but to all of us. While the COVID-19 pandemic affects us all, the health impacts have been worse for seniors, workers who provide essential services, racialized populations, and people living with disabilities, and women. So as of January the 12th, we're aware of over 4,300 active cases of COVID-19 in First Nations communities on reserve, and a total of 11,500 or more since March. And these numbers continue to rise during the second wave or resurgence. And so over the past weekend, there's been a change, observed in the second wave. It's quite important change in that in the first wave, I think many First Nations communities, remote and isolated areas of the country, the territories were spared, for the most part. But with this second resurgence, this second wave, there's been much more spread into the whole of Canada. So Indigenous community leaders have made it clear that challenges with COVID-19 include housing and the real impacts of not having access to health care in many communities, and the impacts of systemic racism against First Nations, Métis and Inuit peoples, as violent backlashes have happened in communities with cases. And one of the challenges, of course, is the lack of data for some of our communities, which doesn't allow us to know with great detail what is actually happening. Next slide, please. So we have seen a lot of the broader impacts of COVID-19, the illness itself, but also the public health measures that have helped us control its transmission. So it's been incredibly challenging balancing the needs of reducing transmission and with the other supports that people need because of the public health measures impacts. Of course, as I said from just now, is that COVID-19 is passed from person to person. So that COVID-19 is about human relations. As humans, we want and need to connect with each other. And as we do that, we can drive transmission, which is what makes it so hard to get this pandemic under control. And we see that violence and substance use intersect with COVID-19, and these impacts are exacerbated then by the health inequities. And the impacts of which I think is going to last much longer than the pandemic itself. So I think one of the key impacts or the dual health crisis that's going on, of course, is the opioid and other substances linked to deaths and other serious impacts. And we saw a change in the drug supply and also some of the difficulties in accessing services because of the physical distancing. So all of these factors compound into driving increasing the opioid-related and polysubstance use associated epidemic. So we can see, of course, many other impacts on the slide, and we've heard how difficult it has been for many Indigenous communities, also not being able to gather or hold ceremonies as they did prior to the pandemic. So this illness has impacted our traditions, cultural practices, and which is extremely important, of course, to identity and well-being. And so I think that's particularly difficult. I've seen time and time again how this pandemic is related to outbreaks associated with funerals, for example, where the grieving process in and of itself can increase risk of transmission. But you can understand we can all understand how difficult it is to move away from some of these fundamental cultural practices. One other change we've seen shifted is in the adaptation of our society is the move to virtual care. So we are on the Zoom call today, and medical care has shifted quite a bit into the virtual care space, which of course has some very positive aspects in terms of digital access, but also speaks to some of the inequities in terms of accessing internet, for example. But I do think that digital access to health services is something that needs to be capitalized for everyone. So we need to integrate these many different dimensions as we move ahead in managing the social and economic impact of infectious diseases. So the next slide. So how do we move forwards from the first wave now into this second resurgence, and then beyond, past this pandemic into the future of emergency preparedness and response? So I took the opportunity to lay out how the complexity of responding to a global public health crisis plays out, to show that the power of collaboration really, and how the commitment of everyone in Canada united can control the virus spread, and how important it is for different sectors to work together with the engagement of communities, with civil society. That is extremely important if we're going to deal with this and other future emergencies. I think that we need sustained effort to improve, to take on the momentum. I think some of our decision makers have, during this pandemic, taken on some of the improvements, for example, in some of the employment conditions, in housing and access to social and health services to better protect people during the crisis. But I think we need to be able to continue to build on this beyond the pandemic and create resilience and lasting equitable opportunities. So despite facing an elevated risk, many First Nations, Inuit and Métis communities have shown leadership, resilience, and community collaboration. And so it's really amazing to see the power of the community in order to be able to address an outbreak. I've seen that in La Loche in Saskatchewan, when they had some outbreaks at this last year, in communities in Nunavut, as they've now driven down the cases back to zero, the Six Nations of Northern Ontario, where the community worked proactively to protect elders. So really what I've tried to do in my annual report is use an evidence and knowledge-based actions for each of these high impact areas that I've laid out here, and emphasize really important things like having sick leave, having employment protection, access to digital health services, mental health services, and getting simultaneously addressing stigma and discrimination in our health systems and our other systems in order for us to move into recovery and in the post-pandemic period. And the next slide, please. So I think as we come to sort of the wrap up, the way forward in the report really is about creating systemic resilience. And I've seen how many different ministers, for example, would get together. So that it's not just the health minister, but it's the finance minister, the ministers associated in charge of social supports, housing, all coming together to address a complex health crisis. Well, this needs to continue, and that pandemic preparedness and planning needs to be multi-sectoral, and we need to be able to scale up cultural safety policies and practices to address the structural stigma that is being faced by First Nations, Indigenous and Métis peoples. really achieving health equity is about increasing resilience, harnessing the power of social cohesion, and leveraging the wisdom of elders and others. And I think countries, for example, if you looked around the world, that have done well, where communities have this social cohesion. And of course, this is coming from a public health sphere, the chance to make sure that people don't forget after this pandemic, because memory is short, to show up public health capacities and in all of its forms. So the next slide, please. So now COVID-19 right now, I do think is into a next stage, if you like, where vaccines have started to arrive in Canada. Many people globally have worked really, really hard to develop, to see these vaccines through clinical trials so that we can ensure its safety and effectiveness. Vaccines began to arrive in Canada in small amounts, started in the end of last year, and it's beginning to roll out gradually at first. And then we expect the supply to increase much more dramatically in the second quarter of this year and third quarter as well. And with the goal of providing access to all people who live in Canada, reside in Canada, by the end of September. That is the goal. And so that every level of government needs to engage and work collaboratively with Indigenous communities and leaders in order to be part of that rollout implementation. And Indigenous Service Canada is our lead department that is pulling together different tables of engagement. And I do think that there is engagement at the political level, but also at the public health implementation level. And these trilateral regional tables are very important in terms of actually getting down into details as to how vaccines are going to be implemented in Indigenous populations using a distinctions-based approach. And so I think, one of the key aspects of making sure the vaccine program is successful is by sharing information about the safety and effectiveness of the vaccine to build vaccine confidence. But it's really through engagement of Indigenous organizations and stakeholders that I think we will get people to take the vaccine. So vaccine is important, but vaccine is not enough. It's actually about vaccinations. The vaccines have to get into someone's arms. So I think, maybe I'll just end with the fact that I felt pretty emotional, I would say, when I saw videos and photos of elders in communities or in long-term care homes getting vaccinated, vaccinators arriving in remote communities with the carriers for the vaccine, was one of the most amazing moments that I witnessed in the past year. So I'll stop there. Thank you.
Thank you, Dr. Tam. I note that there has been a great interest in our communities. There's been a great interest in terms of how COVID is going to actually get to them in terms of access and priority. And in particular, our communities are sort of divided between urban and rural areas. And it's hard sometimes to find the data with respect to the impact on urban communities in particular. But what are the priority roles that the health is going to take with respect to getting equitable access to our people in both sectors?
Yes, so, as I said, there will be enough vaccines for everyone and 2 doses for everyone. The really difficult period of time is now, in this first few months of this year because of the supply is limited. So we are anticipating 6 million doses, or enough approximately for 3 million people in these first 3 months. And then of course the supply will increase. And so we did ask the National Advisory Committee on Immunization, on NACI, to make some recommendations when you take into account the actual epidemiology of the illness, but also many other factors, including ethics and equity. And so based on these recommendations, we know that the fundamental risk factor that is really prominent is residents and staff that are providing care to seniors in congregate living. So we know 80% of the deaths in the first waves was related to this setting. So that had to be a priority. But age, if you looked at all the chronic medical conditions, and age comes out as really the very key risk factor. So one of the ways of rolling out a vaccine program across communities is starting with the oldest age group and then moving to younger age groups, and then healthcare workers who are on providing direct patient care. But the committee really stressed that adults in Indigenous communities where infections can have disproportionate consequences should be prioritized. And then then the next set of vaccine arrives, and the next wave of people will get the vaccine. So how do we sort of ensure vaccines are provided to First Nations, Inuit and Métis populations? So some of it also has to take into account the logistics and of rolling out vaccines that has to be in very cold temperatures and carried in special ways. So right at the beginning, a per capita allocation approach was taken, but also recognizing that in some remote areas, you can't use the Pfizer vaccine, which has to be minus 80 at the time, very easily. So we had to allocate another vaccine, the Moderna vaccine, which is easier to handle, to the territories who wanted that vaccine more than the ultra cold storage conditions of the Pfizer vaccine. So there was many layers of planning. But all to say is that I think we recognize from the federal government perspective, I would say at the political level, Minister Myrle, Minister Haidu, everyone is using their voice in making sure that provinces who are fundamentally in charge of vaccine program implementation takes into account priorities, allocation or the implementation rollout to Indigenous populations. So Indigenous Service Canada, and I work very closely with Dr. Tom Wong, Dr. Evan Adams, that they're facilitating trilateral engagements within the regions, because at the sort of national level, we've been engaging national Indigenous organizations. That's not enough when you're actually in the practicalities of different regions and the rollout. So trilateral engagement within regions sought to be really important, leveraging on the existing tables to support this. And I think that the most important term is co-development, the co-development of vaccine plans to ensure equitable access, but also co-development of tracking mechanisms to look at vaccine uptake, safety, and effectiveness. One of the fundamental challenges for us, at least certainly at the public health agency level, is the lack of data fields being sort of supplied on indigeneity. And there has to be co-developed distinction-based communication plans. So there are two working groups. One's called the COVID-19 Vaccine Planning Working Group that Indigenous Services Canada coordinates, and a Urban Indigenous Vaccine Task Group. So through these mechanisms, there's a significant attempt made to try and ensure access. And communication is really important. We're trying to fund communities and people that are trusted within the communities to provide the communications in the Indigenous languages through elders and other trusted influences. So some of these are the components that are being supported by primarily Indigenous Service Canada, but we're very much engaged from the Public Health Agency perspective. It's not easy, and I think every region seems to be different, and so work is ongoing, I think.
Thank you. We have a question said, Indigenous elders are a source of highly valuable knowledge, often the last ones to speak the native languages. How has that factor been taken into account for the COVID-19 vaccine rollout strategy?
I think some of, and you know, we can provide some of this information afterwards if appropriate. I think that Indigenous Service Canada, our lead department, is trying to ensure that there's culturally appropriate information, evidence-based, knowledge-based about the vaccines themselves and the administration processes. They're trying to look at radio scripts, videos and posters, social media posting and tips. But I do think that just seeing videos or photos of elders getting immunized, I was very emotional actually, just seeing that, and that they put themselves and their communities ahead really in accepting the vaccine and getting the vaccine are some of the most powerful messages I think that can be provided.
Thank you. We have another question with respect to herd immunity. The question was, how effective do you think herd immunity will be in rural and First Nations communities? And do you have an anticipated hopeful timeline when this strategy might be effective?
That's probably one of the most frequently asked. What I can say is that in the clinical trials, which were conducted in tens of thousands of individuals, the vaccines were very effective, over 90% effective in the trials themselves. So if you compare people who are vaccinated, people who didn't get the vaccine, those who are getting the vaccine are highly protected, that population. So that gives us a lot of hope. But that's protection against illness. So the fundamental question being analyzed right now is, does the vaccine protect you against asymptomatic infection? Because if it does, that bodes very well for reducing transmission, even if someone is asymptomatic. So the question of does the vaccine reduce transmission is still being answered. But I think just starting off knowing that they have over 90% efficacy in the trials is great deal of hope. So I hope to be able to update everyone with that answer as we get the information. But what our modelers and everybody who's working at this, throwing in the data as they see it arrives, is that we know that it's likely that quite a high proportion of the population does have to be vaccinated. You have experts saying, 60 to 70% vaccine coverage. But if the virus becomes more transmissible and spreads more readily, you need an even higher coverage for that population protection to occur, where it's not just protecting the person who's vaccinated, but those around them who can't, for various reasons, be vaccinated. So, and you've seen the supply escalation and the goal of providing vaccines to everyone by the end of September. So I would say that, we'll be looking at data as we go along, but until we get to about that level of vaccine coverage, that's unlikely to be the case in terms of herd immunity.
Okay. For another question, the person is asking, if you could change anything, what would you have changed about Canada's initial response to the pandemic?
That's a very big question. All I can say is, as I said at the beginning of this presentation, is probably one of the most humbling experiences of anyone who's worked in public health for a long time. and that it is inconceivable in our collective experience that the pandemic would have this impact, not just the illness itself, but really how the world, how countries have reacted to the pandemic. And I think looking back with hindsight, everyone would say, well, you need to do certain things faster. Should have done X, Y, and Z faster than you did. And I think that one of the questions is, you know, Canada was very much a country that respected individual freedom of movement and mobility, and whether we could have, you know, shut the border or restricted the border to, you know, we've now restricted border traffic for over 90% compared to before the pandemic, where that would have made a difference. And I do think that we did a lot of work that in terms of escalation of our response from the moment that we heard about the emergence of the virus to when the virus really took off in Canada. You know, I just think that, you know, looking back, again, with hindsight, stockpiling more things, having more, you know, capacity in Canada, even from a, you know, what should we do in terms of building up a domestic manufacturing capacities. But in the end, and going just back to the theme of my report, is what has taught me is just to again reiterate the importance of socio-economic factors in our response and health inequities. Because if you think about it, it's the seniors. It goes back to seniors and long-term care. If we taken care of long-term care and our seniors, then that 80% of the deaths were in that setting. So I still come back to think, okay, I know that the federal government isn't directly in charge of long-term care. It's such a complex environment in terms of roles and responsibilities. We need to sort that out, and we need to value our seniors and give them the respect and support that is due, particularly in the long-term care home area. So with a million lessons that will be learned, and we have been learning, I still think that long-term care and how we take care of our seniors, that's got to be the key lesson learned.
Thank you, Dr. Tam. Just one last question. This, with respect to the rollout of vaccines, you are very well aware that our households in Indigenous communities are comprised of multi-family units often, with quite a number of individuals involved. And as the rollout for priority access to COVID takes place, the regulations that seem to be taking part now are to have layers of access starting from high age group through down. But we have our communities, we have people of multi ages packed into small housing. And so I wonder whether a consideration may be given to doing whole households in terms of COVID rather than stratified layers of access.
Yes, and I think that's a very good point. And it is particularly difficult when vaccines are scarce. And soon enough, you get when you get a lot of vaccine, that is not even a question that we need to just encourage people to go line up. But for now, this is how we thought about things for most particularly for communities where you can't keep going back in because of access, and we're in the middle of winter. And so for the territories, just an example, the initial allocation is enough to provide for 75% of their population in its entirety, so that you're not, as you roll the vaccine out very quickly, you'll be able to vaccinate communities of populations as a whole. And the same concept to other communities where it's difficult to access care, but also difficult for vaccinators to go in multiple times with freezers and supplies. I think that in the urban setting, it may be more difficult, but I do think that congregate living and congregate working, those are the conditions where some of the priorities will need to be applied. And that's where the detailed planning needs to take place more at the local level.
Thank you, Dr. Tam, and I'd like to thank you for taking part and being providing access to us. It's important for us to be able to hear from our leaders so that we can work together in terms of solving some of these problems. So again, I know that you have to go to another meeting, so thank you very much for your participation. And I'd like now to introduce Sarah, who will introduce our next session. Thank you.
Dawn, thank you so much. And Dr. Theresa Tam, what an inspirational talk. I think really those words about resilience and also how important it is that we are social, that we think with our heads, but we feel with our hearts. And I'm so pleased that for the next 7 to 9 minutes, I think our hearts are going to be moved, Dawn, as a cultural performance is given, as we rekindle that sense of social connection. Nikki, I'm so thankful that you are willing to join us today, that you've taken time away from being an extraordinarily busy person with 5 kids from Winnipeg. If you would be so kind as to join us, we'll have your camera on, we will unmute you. And for everybody who is going to listen with wonder and awe and have our hearts moved, Nikki, I know you'll introduce yourself and we will return to the scheduled performances beginning with Ms. Kudloo at 11:10. We also want to recognize quickly, there was a lot of questions posed to Dr. Tam that we didn't have the opportunity to get answered, but we at the NCCIH will be looking at how to facilitate possibly having answers sent to you. So thanks again, everybody, for the questions that you posed. Dawn, you did such a beautiful job facilitating them.
Am I on now? I'm not sure.
You are.
Oh, okay.
Thanks, Nikki.
Thank you. Good afternoon, everyone. My name is Nikki Kumaksutiksak. I'm originally from Chesterfield Inlet, but Winnipeg is my home and has been for about 30 years. I'm currently the executive director for Winnipeg's Tungasugit Inuit Resource Center here in Winnipeg. A mother of 5 and a foster mom. I would like to start off by thanking Roberta Stout for reaching out to me, Roberta from the National Collaborating Center for Indigenous Health, for reaching out and asking me to be a part of this event to showcase a little bit of what I do on the side. So I'm also a throat singer, so that's what I'll be doing for you guys. One of the most beautiful things about when I'm presenting a part of my culture is I love telling the story that my grandmother told me before she passed away about the creation of throat singing. Now, depending on what region you're from, there are different stories of how throat singing became to be. This is a story I carry near and dear to my heart. It really shows you the life that Inuit lived, you know, as little as 50, 60 years ago. So here's the story. So a long time ago, Inuit lived in igloos, and there were different roles for different genders. The men's role was to go out in groups and go hunting. Sometimes they'd be gone for days and sometimes weeks, depending on the migration of the animals. The women's role was to stay back in the community and teach the children the way of life in the north, how to be safe around the seawater, how to sew, how to cook. One day when a group of men went out hunting, they never came back to the community to feed the women and the children. Several things could have happened to the men. They could have fell through the ice and drowned. They could have got lost and froze to death, or got mauled by animals like polar bears. And that's just the harsh reality of life in the north and still is today. Because of this, unfortunately, a lot of the children were starving, and mothers being the the carriers and the life givers needed to find a way to feed their children. So 2 women went down to the ocean and they started mimicking different animal noises with their throats. And when they did this, they found that they attracted smaller animals. So that's how they caught their food to feed their children. So a true story of survival. I just love telling that story because it just really speaks to who we are as Inuit and how we just overcome any atrocities that come our way. Today, throat singing is typically done with 2 women and they're facing face to face, looking into each other's eyes, mimicking different noises from the environment. And basically the first person that laughs is a loser. I don't have a partner because I don't like to lose. That's a joke. I actually have 2 daughters. They're teenagers. One is 19, the other one just turned 17. And one's in university, the other one's at school, so I don't have a partner today. So I'll be throat singing by myself for you guys. I've been throat singing for about 20 plus years. I've traveled all over the world. So living in an urban setting and the population of Inuit in Winnipeg has been very small. We are now growing significantly. So it's easier to find a partner, but as a younger teenager, it was really hard. So I really had to learn how to adapt. I really wanted to showcase who I was. I wanted to showcase my identity and throat singing. So I learned how to incorporate a few different types of noises into a throat song. So this is what I call Nikki's one-hit wonder. I hope you enjoy. I can hear everyone applauding. Thank you. Oh, that really gives a workout to your diaphragm. Whew, give me a second. It's been a while since I actually, this is the second time that I've done throat singing on Zoom. Really weird because I don't get to hear anyone's like feedback. I get it. But I know that a lot of people that hear this are like, whoa, this is so cool. So thank you. So that's my one-hit wonder. I'm gonna do one more and then I'll give it back to Sarah. I hope you guys enjoy the rest of your discussions here this afternoon, and I hope you enjoyed my performance. If you would like to reach out to me, just go on to Dungasuugit Facebook page, or you can email me at execdirector@dungasuugit.ca. I'll give the information to Roberta and Sarah. I hope you guys enjoyed that. Thank you again for allowing me to represent my culture. And yeah, I hope you guys have a wonderful afternoon.
Nikki, thank you so much. I know you mentioned that it would have been even more gratifying to see all of us in person and to have our energy and our feedback to you live. All I can tell you is that my phone has been buzzing the entire time that you were performing. Rebecca said that she is getting shivers. I have to tell you, my heart feels quite tense and I feel a bit teary really with the feeling that I've been offered something extraordinarily powerful and unbelievingly beautiful. So thanks for your workout. Thank you for your gift. And thank you for bringing us all together over this sort of strange environment of Zoom. I really can assure you, you are being appreciated from coast to coast to coast. We're so thankful for your energy and for the gift of your time and the gift of your presentation. Thank you again. I think also, Nikki, you have opened an absolutely spectacular and perfect space for our next presenter. Rebbeca Kudloo is the president of Pauktuutit Inuit Women of Canada. Rebbeca was born on the land outside Igloolik, Nunavut, and now lives in Baker Lake, Nunavut. Ms. Kudloo represents Pauktuutit on the board of directors for Inuit Tapukirikana-Tami and the Inuit Circumpolar Council of Canada. Outside of her work with Pauktuutit, she has dedicated her life to education and community-based counseling. Having spent time in the same room as Ms. Kudloo, I have to tell you she is a remarkable and powerful presence, and I, for one, am extraordinarily excited to be here today and have her wisdom given to all of us. Rebbeca, Ms. Kudloo, I look forward to your presentation. Thank you.
Can you hear me now?
Yeah, Rebbeca, we can. And you are on camera and everything is perfect.
Okay, first of all, Nikki, that was beautiful. It made my heart soar. It made me proud to be Inuk. Good afternoon. My name is Rebbeca Kudloo. I'm president of Pauktuutit Inuit Women of Canada. I am pleased to be here with you today from Baker Lake, Nunavut. Pauktuutit, incorporated in 1984, is the national representative organization of Inuit women. Today, my remarks will focus on gendered aspects of COVID-19 and domestic violence. Across Inuit Nunangat and in urban centers, Inuit women and girls experience deep inequities that disproportionately impacts their health, well-being, and economic stability. Inuit do not share the same standards of living or access to health and social services, food, housing, employment, education, or socio-economic development as most other Canadians. The pandemic is deepening pre-existing inequalities and revealing vulnerabilities in social, political, and economic systems. In turn, there are increasing the harmful aspects of the pandemic and have plunged into women's rights even further into deficit. For decades, Inuit have faced an acute housing crisis resulting in severe overcrowding, substandard homes, increased exposure to vulnerable diseases, and a lack of affordable and suitable housing. The Public Health Agency of Canada has advised citizens to observe physical and social distancing measures to avoid contact with others, including maintaining 2 meters between people, avoiding crowded places, and staying home as much as possible. However, physical distancing is difficult, if not impossible, for most of our people because of the large proportion of Inuit living in crowded housing in Inuit. This results in a distressing domino effect, as overcrowded housing is then linked to higher rates of family violence, from which Inuit women need to escape. However, shelter shortages meant those experiencing violence and abuse in their homes often have no place in their community to seek safety. As I said earlier, with the wind chill today, it's minus 45 out there. So if a woman is trying to escape, she has to go out there in the cold, which is another danger. Urban emergency shelters and transition homes are already grappling with significant capacity challenges, and the pandemic has only made things worse. Some shelters have had to reduce the number of clients they can accept, sometimes by half or even more, due to physical distancing measures. The chronic and discriminatory underfunding of healthcare and associated infrastructure and support in Inuit communities severely limits our capacity to manage serious outbreaks of like COVID-19 and TB. Most communities in Inuit only have a health center staffed by nurses who must rotate in and out of our communities. For expectant Inuit mothers, traveling south to give birth is a routine. My granddaughter left before beginning of December to have a baby. She just returned yesterday. So it puts a lot of stress right now, especially with COVID, for family members to send and pregnant women to go south to have babies. I wish to direct your attention to the recent devastating case of a Nunavut woman, Kudloo, who traveled to Winnipeg in November to deliver her child. Kudloo was diagnosed with COVID-19 shortly after giving birth and separated from her newborn daughter. She spent over a month on a ventilator before she died on January the 2nd. Kudloo was 34, and now her 5 young children are left without a mother. This tragic death is yet another example of the urgent need for midwifery services in every Inuit community. Every Inuit woman should have access to safe and compassionate pregnancy, birth, and postpartum care. They should not have to leave their community and circle of support to receive it. Also, they also leave the other children in care of family members who are probably in overcrowded housing and food insecure. So that's another worry. For many years, Pauktuutit has advocated for community-based childbirth. We have also documented traditional midwifery practices to help save the knowledge of elders before it disappears. Pauktuutit has long called for attention to the disregard of Inuit women's rights, as well as the lack of basic access to culturally safe and competent healthcare. Going forward, It is Inuit women's empowerment in socio-economic, political, and health matters that will determine whether we can close the inequity gaps in access to services and programs between Inuit and other Canadians. To achieve this, it is essential that Pauktuutit is treated as an equal partner with federal, provincial, and territorial governments in decision-making processes about Inuit women, families, and communities. Pauktuutit continues to advocate for immediate investment to increase the safety and security of Inuit women and children. Kuyan nami.
Rebecca, thank you so much. I've always believed that the powers of stories are the power that has the potential to change the world. I think I speak for all of us when I say I imagine it took a great amount of bravery and emotional strength to share the stories that you've just shared with us. And I sincerely hope that we can learn from them. Rebecca, I'm extraordinarily grateful, and on behalf of all of the participants, thank you so much for sharing. We do have a series of thank yous popping up through the question and answer box, but I know that you have to step away, Rebecca, and we at the NCCIH will ensure that if there are questions specific to your presentation, we'll have them forwarded to you and we'll facilitate answers getting back to participants. Thank you again, and I speak again for many participants who are sharing thank yous in the question and answer box. We'll move now with your kind and generous and incredibly powerful words and stories, Rebecca, back to Dawn Fiddler. Dawn, so that you can introduce our next speaker. Rebecca, thank you again so much.
Okay. Thank you very much, Sarah. And thank you as well to Rebecca. You caught my attention when you mentioned it was minus 41 where you happened to be. I remember growing up in Saskatchewan, how cold that can be. We're now going to turn our attention to Neil Belanger. Neil Belanger is the Executive Director of the British Columbia Aboriginal Network and Disability Society. And he has over 30 years experience working with Canada's Indigenous and non-Indigenous disability and health sectors. He also serves as an advisor to many other disability related roles as such. So please welcome Neil Belanger.
Great, thank you, Don, for that introduction. Hello, everyone. As Don said, my name is Neil Belanger. Before I provide you with a brief presentation about our organization and some of the issues related to COVID and Indigenous disability, I'd just like to take the time to thank Elder June, as well as Nikki for her performance, and the other presenters who have already presented today. We'll like to acknowledge the Esquimalt and Songhees Nation, traditional territories I'm presenting from today, and also take the time to recognize each of the territories you are participating from across Canada. So as Don said, my name is Neil Belanger, and I am the Executive Director of the British Columbia Aboriginal Network on Disability Society, or BCANS. I am also a member of the Lakehead clan in the House of Nicodane within the Gitxsan First Nation. I'm very pleased to be here. Next slide, please. So our organization, BCAN, is an Indigenous disability organization based out of Victoria. We have special consultant status with the United Nations, and we work actively with the UN on Indigenous disability issues, both domestically and at the international level. We also provide a number of other programs and services across Canada and in British Columbia, which includes Indigenous disability case management, Persons with disabilities benefit adjudications, when we do that on behalf of Indigenous Services Canada. The Registered Disability Savings Plan program. I mentioned the Convention on the Rights of Persons with Disabilities. We do a lot of work within accessibility for First Nation communities. We work in employment, and recently we have implemented the COVID-19 program here. And our mission is to advance the unique disability and health priorities of Indigenous persons through collaboration, consultation, and the delivery of comprehensive plans. Next slide. So this slide here goes back to what Don noted. So we've spent our time to make sure that we're really connected to government and community organizations and departments that are influencers in policies and decision making across Canada, to make sure that the priorities of Indigenous persons living with the disabilities are known by government. I won't go through all these, but we are part of the Federal Minister Carla Qualtro's National COVID-19 Disability Advisory Group, as well as the Provincial Minister's here COVID-19 Advisory Group. The information that we bring to the table comes from the communities and clients that we serve, and the barriers that they have brought to us, and we deal with through our day-to-day. So in Canada, many of you may know that the rate of disability is approximately 22%. Indigenous persons living with a disability, though, experience quite a larger rate at about 30% and much higher in other age groups, higher age groups. We know that from 2016 statistics, there are over 500,000 Indigenous persons living in Canada of all ages living with a disability. Unfortunately, though, across Canada, Indigenous disability still doesn't seem to be a high priority. This is despite the fact that Indigenous people living with disabilities predominantly live in poverty, experience higher unemployment rates, lower educational levels, higher incarceration rates, and too often experience discrimination and racism when attempting to access services that are designed to assist. COVID-19 has not, created these barriers. They were there before, but they have certainly amplified those barriers and created new barriers for the population to deal. Next slide, please. So across Canada, within the disability community, encompassing both Indigenous and non-Indigenous person groups, the overwhelming experience has been that persons with disabilities during COVID-19 have been largely excluded during this pandemic. Their needs, their increased needs, their disability and health-related needs have not been addressed at the same level as other non-Indigenous Canadians. This includes the clawback of the Canada Emergency Response Benefit by several provinces for their members living with a disability who are eligible for the benefit. So many provinces across Canada provide persons with disability benefits. With the introduction of the Canada Emergency Response Benefit, some of those provinces clawed those funding. This was a zero gain or zero support for people who are in receipt of persons with disability benefits. As well, there was very limited support provided across Canada to address the increased needs, particularly for urban communities and Indigenous persons living in the urban center. This includes access to personal protective equipment, transportation, increased costs for groceries and other necessities. And through the federal government of Canada, we saw that there was no specific disability-related funding targeting Indigenous persons living with a disability. We saw the government of Canada roll out, support throughout the pandemic to date with another recent announcement, but none of those funds were specific towards Indigenous persons living with a disability, either in the urban or within Indigenous communities across Canada. We also saw that one program that they did introduce was a $600 benefit for those persons who were eligible for the disability tax credit. This was a very exclusionary process, because with the disability tax credit, you have to apply for it, and there's often a cost for it. Most of the people we serve live in poverty, and the disability tax credit can cost anywhere from $0 to $200 to $250 to pay for a medical professional to fill out the form. Most of our members can't afford that. Subsequently, they couldn't apply. So even though they were eligible, they missed out on that one-time payment of $600. Government did extend it till the end of December, but still, without the resources to be able to pay for the application process, it was an effort of futility for many. Next slide, please. Since COVID-19 has occurred, we've seen significant concerns and barriers that are experienced by the population. And what I'm going to go over to next is certainly not all encompassing. Some of the more prominent areas that we've dealt with shouldn't be considered to think that these are all the areas that our clients and our communities are dealing with. Some of these areas have been addressed, like it says in the slide, to some degree, such as personal equipment within First Nations communities, but still the costs for groceries and for PPEs in the urban centers exist. So one of the things that we're dealing right now with our clients and our communities is in relation to the vaccine and the development and rollout of it. So we get a lot of concerns from the members we serve that the development of the vaccine was way too fast. It can't be real or it can't be effective. So there's a lot of apprehension. We have multiple concerns for the effect of vaccination on the elders and those with compromised health. More concern comes from clients who live with disabilities that they will not be prioritized to receive the vaccination. We put on the back list with other segments of our population being prioritized. And many of the people that we serve are influenced by alternative media sources and include concerns of government genocide, of Indigenous peoples again, and the vaccine being used to help control or curb social activities by them. So there's a lot of misinformation out there about the vaccine, and we haven't seen an effective job by provincial, territorial, or federal governments to address that, particularly for Indigenous persons living with disability. We know that some work has been done in that area, but not enough. And the government needs to step up and talk about why the vaccine was able to be developed so fast. They need to talk about the international and organizational cooperation that's happened to make it go that fast. Next slide, please. So again, we have a number of concerns within the healthcare system itself across Canada, as it pertains to Indigenous persons and Indigenous persons living with disabilities. These are further complicated by the systemic discrimination and racism towards Indigenous peoples when they access health, highlighted in the recent In Sight report that was commissioned by the government of British Columbia, as well as Bill C-7, currently under Senate review. So in relation to the In Plain Sight report, many of you may be aware that in British Columbia, the provincial government had commissioned a report to look at systemic racism in the healthcare system. And it's a fairly scathing report. But the situations that Indigenous people and Indigenous people living with disabilities face within the healthcare system and other systems across Canada is similar. Well, during this time, we see that the government is engaging in changes to federal legislation as it relates to Bill C-7, which is medical assistance in dying. And this, again, has huge ramifications on Indigenous persons living with a disability, particularly when the government has chosen to do this change during a time of a global pandemic, not engaging Indigenous persons living with a disability in that process to an adequate level. In fact, engagement has been done very minimally. So there's a number of concerns for the welfare of Indigenous persons living with a disability when they access healthcare systems because of the racism and because of the marginalizations and the overwhelming perspective that many within healthcare have of Indigenous people. So this has resulted in reluctance to access healthcare services due to the real and perceived racism. And concerns that Indigenous persons living with disabilities will not be given equal access to life-saving COVID-19 interventions, the triage policies. Family members and support staff are being denied access and the ability to be supplemental care providers within healthcare facilities. Sometimes the personal protective equipment utilized by hospital staff is not conducive for Indigenous persons from the deaf community who read lips for communication. And again, limits are placed on the number of family members accompanying a patient. So that has impact on someone who's a single family or a single parent with children, and whether or not they can actually go to the hospital, seek care, and bring their children in. So it's all over the place. Next slide, please. So another area, of course, which has been mentioned is housing. Access to safe, accessible, and affordable housing has been a priority for Indigenous people prior to COVID-19, and it's now even more so. The pandemic has amplified that urgency. So as we've heard already, many Indigenous persons living with a disability live in overcrowded and often unsafe housing conditions, making isolation almost impossible. Many Indigenous persons living with disabilities couch surf. They live on the streets and they use public or friendly showers and laundry facilities, increasing the possibility of exposure and transmission. And if they are in the position of couch surfing or staying intermittently at other places, they're not always prioritized as being homeless, so they are ignored. Again, we know that limited and overcrowding and housing within Indigenous communities, again, that too increases the likelihood of exposure and transmission. And we see that sometimes, even with interventions that we put in place as an organization or even the government, we see that there's unintended consequences. So when we do find housing for some of the members that we serve, sometimes, for example, we assisted a gentleman not long ago, spent 20 years living on the streets, couch surfing, finally found appropriate housing during the pandemic. And now he's lost all connections to his social networks. He lives in isolation now. He doesn't have access to computers or Wi-Fi or internet. So we see that even though we're trying to implement good things to protect someone, sometimes they have negative ramifications. Another example is what we see the government buying up hotels and making them into homeless shelters or residents for persons street entrenched. Again, even though it's a good intervention, many times we've had people that are housed in those facilities prior to the government buying them, and they get kicked out when the government does to make room for others. So, and this was not done maliciously, but it just shows that sometimes the lack of planning and the involvement of Indigenous organizations and Indigenous persons living with disabilities should be more prominent and it should be enforced by all levels of government. So access to services, and we have seen across Canada with the full or partial closure of communities and external service providers, Indigenous peoples living with disabilities are faced with very limited support to meet their needs. So we know that request for mental health services has increased exponentially, largely due to isolating effects of the pandemic. With the closure of public facilities such as libraries and recreation facilities and other public usually public venues, access to free Wi-Fi has diminished considerably. And when you're living in poverty and your library is closed in your region, and there may be some place down the road in the city, particularly for urban dwellers, you need transportation to get there, and sometimes that costs money. Sometimes you don't have that money for there. So isolation needs to be a very big barrier that people are experiencing, being disconnected from their social network and the communications. And information is vital when you are trying to apply for disability supports or health supports. You need information, and it's required to be sent electronically. So again, closure of recreational facilities impacts the person's ability to swimming and to exercise, which is critical for rehabilitation. And without that, with isolation, it amplifies existing health and disability conditions. We've seen a reduction in respite services across the board, particularly for childcare and access to, as well as access to specialized services such as OT. This means that parents are put in a position that they are at home more, caring for their family members living with a disability, and don't have the supports to spell them off, increasing their isolation and the pressures on their mental wellness and their mental well-being. This includes parents that have had to now take over the teaching role as well in their home, and having to deal with sometimes their children who may have behavioral issues due to their disability with very little support. This happens both within community and urban centers as well. Again, adding to the frustration and negative impact on their mental health. Next slide, please. So again, with the closure of schools and increased remote learning, many Indigenous students and families living with disabilities don't have the technology or financial means to continue their studies adequately. This includes access to a reliable computer, able to access internet, or you might have a computer in your house, but you have 3 or 4 students who are living there. How do they get their schoolwork done? Again, timely and accurate access to communications and in a manner that is conducive to persons living with a disability continues to be a challenge. And even for here, when we look at our presentation here today, and I'm not sure this is accurate or not, but I don't see any captioning here. I don't see ASL or LSQ or ISL, so ASL, American Sign Language, French Sign Language, Indigenous Sign Language, captioning, which is the writing, and even presentations in plain language, including my own. So this itself in the menu that we're doing excludes participation by Indigenous persons, families who live with a disability to be part of the bigger process and to learn information and send information out. So, and we see this across the board and across Canada, that although it's gotten better, still communications in a manner that is conducive to the individual and family is a challenge. And getting that information and communication to communities is a challenge as well. So as well, we need increased support for Indigenous persons who are living with a disability who are escaping violence. And more access to healthcare practitioners who are required to be able to fill out applications and medical reports that assist in getting somebody support and services and the benefits that they require. Next slide, please. So, and again, I want to ensure that you know that these points of priorities are not all encompassing. I mean, there's transportation issues, there's cost for groceries. I mean, there's too numerous to go through in a short presentation. But what is clear is that things have to change, and the pandemic has been a big. Well, it's been an eye opener for non-Indigenous communities. I think, and non-Indigenous population, but for the people that we serve, these are things that they've dealt with, live with, and experience on a daily basis. We have to take a different path, and we have to think differently as we move forward. And so to ensure that Indigenous peoples living with a disability, their needs and their disabilities and health priorities are known and addressed during a time of a national crisis and ongoing, some of the recommendations I've listed here can be implemented. And that's one of the big things is there should be a creation of provincial territorial disability advisory committees, Indigenous disability advisory committees, disability advisory committees for government with members from urban and Indigenous communities that they can help direct and help talk about the plans for post-pandemic and going forward. As Dr. Tam said, this will happen again, and we need to be in a position where we're prepared and not reacting, but actually be able to roll out services in a manner that's conducive. Government of Canada, through the throne speech, has announced that there will be an implementation and development of a Canada Disability Benefit. That benefit needs to make sure that it has proper, adequate funding support. What can't be so small it doesn't make a difference. There has to be commitments from provincial and territorial governments that they will not claw this back. The Government of Canada has to step up. They do start using their power under the social transfer that they can exercise. We need to have more focused on provincial, territorial, federal initiative and policies and legislation to eliminate racism and discrimination towards Indigenous peoples, including those living with disabilities within all government systems, health, social services, the justice system. We have to take a stance here. This is nothing new. The pandemic didn't create this, but we're seeing more and more during the pandemic. And we need to get a review and a focus at the Indigenous disability lens on funding and support, not to be specific to Indigenous persons living with a disability, and that's within provincial, territorial, and federal jurisdictions. It can't be a happenstance. There has to be targeted supports created for Indigenous persons living with a disability, so that they can be active and included members in whatever community they reside and have their needs met. They have to have the opportunity to thrive. This has not happened yet. And within organizations and communities, there needs to be ongoing flexibility in delivery of programs and services that are available to Indigenous communities and organizations and their members living with a disability. And that means taking a hard look at some of the core programs, such as, for example, non-insured health benefits. And when we have situations like a pandemic, when we have members trying to flee violent situations, that those fundings can be used, that funding or that funding envelope can be used to address those things, to get them out, to get them support, rather than the rigid outline that's restricted. Next slide. Please. Next slide.
I think they're going to advance your slides, Neil. We're just at close to time. So, but you're, I think, on your last slide. Thanks so much, Neil.
Thank you, and I'd just like to thank everybody again. If anybody wants to reach out to us or give us a call or more about us, or if there's anything that we can do to assist you, please contact us. We'd be more than happy to be involved. Thank you.
Thank you, Neil. Appreciate the very descriptive presentation of a very important subject. And reminder to those still on as participants, we will have a question and answer session after the next session. So again, thank you very much, Neil. And please, for those of still listening, pass on your questions and we can share them at the end of the next. So Sarah?
Thanks, Dawn, and Neil, thank you very much. I found myself being extraordinarily moved during your presentation, and I know we're seeing questions come in by people who have been similarly moved. It's a remarkably great privilege to introduce our last speaker to everybody who's participating in this amazing webinar. Dr. Myrle Ballard is Anishinaabe Ojibwe and a fluent Anishinaabe language speaker from Lake St. Martin First Nation. Myrle is an assistant professor and an Indigenous scholar in the Department of Chemistry, the Faculty of Science at the University of Manitoba. Dr. Ballard received her PhD in Natural Resource and Environmental Management with a focus on Anishinaabe language systems, particularly around gender and language. She is currently co-lead on a CIHR-funded research project concerning COVID-19 and the impacts on Indigenous-led countermeasures to coronavirus and other pandemics, then, now, and into the future. I had the pleasure of making Dr. Ballard's acquaintance before this webinar began, and I can tell you she's going to rock this presentation and that you're going to thoroughly enjoy what she has to offer. Myrle, they'll start your cameras, and we really look forward to you moving us forward.
Good afternoon. Can you hear me?
Yes, you're perfect, and we can see you, Myrle. Thank you.
Okay, I'm going to start my presentation now, and I like the introduction, and I hope I do rock it, rock the presentation. First of all, I want to thank the organizers for inviting me to do this presentation. And I want to acknowledge the traditional territory I'm on, which is Treaty 1 territory of the Anishinaabe and homeland of the Métis people. My talk is about the social and cultural impacts of COVID-19 on public health policies and services for Indigenous people. And just an introduction, we have a project that we're working on, which is funded by CIHR, and I want to acknowledge my colleagues, Steph McLaughlin and Dr. Ramona Nekaway. And we're evaluating the implications of pandemics in collaboration with Indigenous communities across Canada. And I'm going to be addressing some of our work with this presentation. When the pandemic first started in 2020, when it was first announced, Manitoba had 0 cases amongst the First Nation communities. We had 0 positive cases around April, May, June, and during the summer. And this past winter, the positive cases skyrocketed with First Nation communities in Manitoba. And there's been a lot of outbreaks, and the Canadian Army was called in to a few of the communities to assist in fighting the outbreaks. For example, Shamattawa First Nation, they had 70 to 80% positive cases, and they had to call in the Canadian Army. When we talk about the social impacts or the cultural impacts resulting from the policies that we have to follow as a result of COVID-19, First Nations are doing amazing. They practice social distancing. They don't allow the outside people that are not registered with the First Nation communities to enter. They have roadblocks, they have checkpoints, they check temperatures, etc. They're suspending non-essential services throughout First Nation territories. And one of the things that I really noticed, being First Nation myself too, that there's a lot of people going back to the traditional medicines and going back to the land as well. The First Nations started setting up checkpoints throughout their communities. And they started this last summer. For example, this is with one of the communities in central Manitoba. And when you go to the checkpoint, they ask you where you're from, where are you going, and sometimes they will deny you. They will ask you to go back. But the interesting thing is when you talk about the jurisdiction between First Nations, between the province and the federal government, we fall within the federal government, yet our communities fall within the jurisdiction of the provincial, like we're tossed back and forth. These checkpoints, you can find them with the First Nation community, but you don't find them with the nearby towns. They don't have checkpoints. And when you start doing analysis between the checkpoints, First Nation communities, and the nearby communities, where the disease is coming from, with the high rates amongst the First Nation communities with the second wave. They travel back and forth to go get groceries, because a lot of the First Nation communities don't have stores within the communities, so they have to leave the community to go grocery shopping. Many of the First Nation communities in northern Manitoba are considered remote. During the summer, the only way to access them is to fly in. And during the winter, they have winter roads going into the communities. So during the summer, when it was relatively low, they could only access the flying in and out, and travel was limited, because to fly back and forth, it's very expensive. It's more expensive. The cost of airfare is more expensive to go to the northern communities than it would be to fly to Australia. And during the winter, they have the winter roads, and they started driving into the communities now. and there's a lot more access, but they still have the controlled entries as well. And within the communities too, when we talk about the social impacts, there's no roads in a lot of these communities. They walk, people walk, and the roads are very poorly maintained. Housing is very poor. There's a lot of overcrowding. And you wonder why there's an outbreak with the First Nation communities. Okay, next one then.
Next slide.
Yeah, next one.
Next slide.
Yeah.
Perfect.
And a lot of houses in the First Nation communities are very, they're dilapidated, they're overcrowded, there's a lot of mold in them, the circulation of air is very poor, and you wonder why there's a lot of outbreaks. Okay, next. And a lot of First Nation communities don't have running water. They don't have drinking water. They don't have plumbing. They don't have the luxuries, the necessities that we have, that we're used to living in other urban centers. For example, we just go to the tap to turn on the water. We just use the washroom and we flush. And a lot of First Nation communities don't have these. These are the ones, especially in the north, and a lot of First Nation communities will still use the outdoor toilets. Next. When we talk about the social impacts and the cultural impacts. The social impacts are some of the policies is you stay 6 feet away. And the social distancing is 6 feet away, and the First Nations people, we're very close people. We like to socialize. We like to be with one another. We like to be with families. Whenever there's a death, we like to be with the family to comfort one another, and that's our culture. Because of the COVID restrictions, of the policies that are put in place, we can't do that. When a person dies, for example, my cousin was in the hospital. My nephew was in the hospital during Christmas, and he passed just before Christmas. We couldn't be together as a family. We had to congregate outside in the parking lot of the hospital with the family, and that's how we got together. And we couldn't sit with one another. We had to stay inside our vehicles. And these are very very trying times for Indigenous peoples, the First Nations people. Whenever there's a death, we always have wake services. Now, when a person dies or someone dies, they get released to the funeral home. Then from there, there's a little bit of viewing, 5 people allowed inside, and they practice a social distancing. Then from there, they go straight to the burial site. And this was taken in between Christmas and New Year's, and this was my nephew. And it's very different, like it's kind of surreal to experience that, like what goes on now versus what we're accustomed to, the getting together of funerals, being with family, comforting one another, and the wake services, etc. Next. One thing about, when we talk about the Mother Nature, when we talk about culture, and because Indigenous peoples are really close with the land, we know what's going on with the land. And the one thing people noticed about this summer, the ones living close to the land, there was an abundance of crops. Like these are Saskatoons, and this is my mother picking the Saskatoons right inside her yard. There was such an abundance of Saskatoons. Like it's as if Mother Nature is compensating for what's going on, bringing relief to the people, and going back to the land and getting the medicines, picking the medicines that are going to heal you. And a lot of people are going back to the land and just being around the land, just looking at the water, and that's what a lot of people are doing. And some of the people, that I know that tested positive, they're using medicines from the lands to deal with being tested positive for COVID, and that's really helping them. Like they're testing positive, but they're coping by using the medicines from the land, so it's not as severe. Next. Next. Part of the thing that we're doing, I just have 1 minute, is we're doing a lot of infographics for the public. For example, this is one on lateral kindness, and we have an infographic artist on our team that's doing a lot of amazing stuff. And this is spreading lateral kindness. Next. And back to school basics for children. Next. And we have Cree words of the week. We started doing Ojibwe words too. And this is a part of responding to policies. For example, this one is Akwasiwin, which means illness. Next, please. And this is a Kakage. We have a video. If you wanna find out more about this video, and you can contact me. This is a puppet that we use to convey the message about what to do regarding COVID, and this is done by a puppeteer, Samson Hunter. Next. And we have an app coming out. This is available on Apple. It's ready to go. And just to go to your app store and download COVID-19 Indigenous. And this is an app that's available for Indigenous people in tracking their COVID outbreaks within their community. And it's an app that will be used for real-time data. And it's going to be an app that'll be used for people to manage their own data and for managing their own stats. So we're excited about this. We're going to have a promo within this week or next week. Next. And we have a conference coming up May 20th to the May 20th to the 22nd, and it's an international conference. We're going to be the hosts, and the information is at the bottom there if you want to register to be part of it, or else if you want to make a presentation, just go to the link, the contact information. Again, if you need more information, I think this is going to be available on the NCCIH website. Next. And these are some of the credits, and I want to thank you for listening to my presentation. I think my time is up.
Myrle, thank you so much. In order to move us to the next stage, before we move to the next stage, Myrle, I just want to tell you I'm extraordinarily sorry about the loss of your cousin. I'm so thankful that you're willing to brave the emotional turmoil that it takes to speak about the realities that are impacting us so intimately at the scale of our family. Thank you so much, and thank you for reminding us about lateral kindness. You did rock that presentation. You were spectacular. Thank you so much. It's been a real honor to have you be part of the webinar this afternoon. Dawn, I know that you're going to start us off in a wonderful and good way by bringing us some of the questions that have been popping up.
Thank you, Sarah. Yeah, we're going to now have a short question and answer session, and we'll do this way. I'll ask a question, and then Sarah will ask a question. We'll go back and forth. And we're running a little tight, but we'll try to get at least 10 to 15 minutes of questions as best we can. So the first question is to Neil. And Neil, thank you very much for that presentation on disabilities. If one wanted to have a presentation that would be an example of the impact of social determinants on health on the community, the way you presented your work, that would serve as an excellent model to show the impacts of that on community levels.
Thank you.
Question with respect to homelessness. I know you've touched on it, but what is the relationship of homelessness to disability? And what difficulties do we have in terms of providing priority access to COVID-19 treatment on the services of this particular community?
So, of course, disability and homelessness are closely related, and they intersect multiple sectors and jurisdictions. So, for example, am I speaking? I'm good?
Yes, you are.
Oh, good. So for example, if we take a look at employment, right? So we know that Indigenous persons living with a disability are underemployed. So that impacts your ability to earn a living wage, which impacts your ability to actually be able to have an apartment or a home. We know that across Canada, disability benefit rates are extremely low. Particularly, if you take a look in Toronto or Vancouver or here in Victoria, where a one-bedroom apartment is $1,300 a month, and the maximum you get on provincial persons with disability assistance is $1,152. You can't make it. Some provinces, the assistance is $758. So you either have to go into settings that may not be conducive for your health and welfare, dangerous settings, where people are using, or you're living in precarious situations where you may be exposed to violence, or homes that are not safe, they're moldy, whatever the case may be, inaccessible. So the result is, for many people, is to get out of there and to go and couch surf or have to look on the streets where they may even feel safer. Now we're in a position of how do you get housing for those individuals living on the streets in a city where, one, there may be a shortage of housing, but two, it's financially inaccessible. Government housing support systems are overwhelmed, and there's like 2-year waiting lists to get on. So, with COVID and the government buying up hotels, it really puts light on the thing that if we want to make change can happen. It's not always a matter of money, like we always hear, there's no funds, we can't do this kind of stuff. You know what? They snapped up hotels all over Canada to provide housing for people, in an effort to stop the transmission of COVID and people getting it. Well, let's take the same priority now in a non-COVID world when that happens and say, let's just get people off the street. Let's give them a home to live in. Buy some more hotels, do whatever you need to do, provide the resources. So without those things and without those resources, again, a priority for people who are homeless or street entrenched. Getting the COVID-19 vaccine is a priority because they're transient. They move around. They don't have a fixed location. So we have to come up with strategies where organizations in the community are being targeted to get those people who are living without a home or are street entrenched the vaccine. I mean, this stuff can happen. It shouldn't take a pandemic to make the change we need. We've seen it can happen now. Now it's going to be up to the provinces and the territories and the federal government to actually step up because we know it can happen. The excuse that there's no funds or we have the inability, it can't wash anymore. We have opportunity now to see significant change. And if we don't do it, well, shame on us. Thank you.
Thank you, Neil.
Neil, thank you very much. I think this question is really applicable to both you and to Myrle. So I'll ask the question. Maybe Myrle, you'd like to start with the answer. This is from Gregory, who has noted that vaccine misinformation is a really big problem in their region. There's conspiracy theories circulating on Facebook, helping to forward various activist sort of ideological agendas. The question is, are there any strategies to address the issue of vaccine misinformation? Myrle, if you wanted to start, and then Neil, maybe just follow up with your voice and ideas.
Yeah. Well, we have a question that's on our app that asks which vaccine is being used, whether it's Moderna or Pfizer. But for the First Nation communities, I'm going to speak for Manitoba. Most of the vaccine that's going out to the First Nation communities in Manitoba is Moderna. So I guess coming from questioning Canada's intentions. Canada has got a long history of trying to exterminate First Nations people, and changing the definition of an Indian with the residential schools. Trying to take the Indian out of the Indian. The 60s school, but the list goes on and on. And there's the Indian Act that still exists, managing the Indians. And this is my personal, why is Canada trying to save the Indians now when it's always been trying to exterminate them?
Myrle, thank you. Neil, do you have any thoughts?
Sure. I mean, some of the things that are going to happen, I mean, we have a new president in the United States, so some of the misinformation, it won't be coming over the borders or on TV anymore, hopefully. As well, it goes back to some of the things that Myrle says and the marginalization of Indigenous people, across Canada for so long. And even if we looked at the last pandemic where the government sent out body bags, and I have to believe it was an error, but people remember that, and people say, yeah, that's exactly right. And if you look at the legacies of residential school in the 60s group, the day school, and now the insurgent and higher profile of racism within healthcare and all the systems, of course, communities are going to be concerned. I mean, why wouldn't you be? Canada is not a conducive place if you're an Indigenous person, in many aspects. So the government needs to take a concerted effort, provincially, territorially, and federally, to actually make that reach out. And they need to use Indigenous Services Canada, and they need to give information in plain language and accurate information. So we asked the same question when we were sitting with provincial governments and health officers there. Why so fast? This, gives everybody concerns. All of a sudden you have this vaccine where before it took 3 or 4 or 5 years to get it. Why is it so fast? They explained to us the unprecedented international cooperation, the organizations not hoarding information, and a global effort to get a vaccine that could be distributed. Well, people need to know that, because if you don't know the information, you're going to make up the information. It's not just in relation to COVID, it's in relation to anything else. And when you're influenced by other outside sources like alternative media, like we talked about, perpetuates and keeps going. And you can always find correlations to support your position. So timely, accurate, and ongoing information is essential to communities and organizations, both within Indigenous communities and urban communities.
Thank you very much, Neil. And this question is coming from Jesse Salas. And just a reminder, Sarah, you will have the honor of giving the last question following, and then we will have closing. This is for Myrle. And Myrle, you mentioned people who are experiencing COVID-19 are returning to the lands and using traditional medicines to help with the symptoms. What traditional medicines are people using to help with COVID-19 symptoms or others?
Yeah, they're using the ones that are commonly found and that are readily accessible. For example, they're using cedar. What they're doing is they're burning cedar, or else they're making, they're boiling cedar, and they're drinking the boiled water from the cedar. So there's both ways because cedar cleanses the air, and that's what they're doing. Plus, they're using wike as well. Wike, which the common name is ratroot, and there's a lot of people that picked that during the fall, and they got it ready for winter to use.
So are these being effective in the communities?
What's that? I'm sorry?
Are they being effective as treatments?
Yeah, they are. They are, because I know people that tested positive, and that's what they're doing, and their symptoms do not get worse. They just test positive, and they just go about their activities within their homes, so they don't go out, like they have to isolate. They know that, but that's what they're doing.
Okay, thank you.
Thanks so much, Dawn. I'll just summarize a couple of observations that have been being made in the question and answer box. And they're quite heart-rendering observations. A number of folks have observed that they're appalled and upset about the statistics that are being shared. I think Neil's presentation brought home some upsetting information. And at least one participant has observed that they remember growing up in conditions that are very similar to what both participants have been describing and speaking about, and that it's really heartbreaking, despite, I think, as both of you have observed, the incredible resilience and the incredible power in the local place and of people gathering. So I think in a sort of summative question, what participants may want to know briefly are both your thoughts on how we might move forward and what the lessons of COVID right now and the socioeconomic impacts on Indigenous people might be teaching us for the future. Neil, do you want to start? And Myrle, you can take us home before our elder closes.
Sure, and thank you, Sarah. I mean, we need to mobilize as a community. That's one thing, right? We need to stand with a voice, and that voice needs to come from community. Not always the 5 representative organizations are often that connected to what we're doing, right? And they don't always get the information. So we need to have a community voice. We need to put people in leadership roles that will actually take a look for Indigenous persons living with disability. You know, not only during a time of crisis like we're going through now, but for all times. We just haven't had the priority ever. And our organization has really tried to move the priority forward, and we've done a good job for a small organization. But that job is, you know, to be finished, it's way down, long ways away. We need to get the non-Indigenous disability community and non-Indigenous health communities to support us as well. We can't do this alone. And those organizations and communities that are not Indigenous, they need to be curious about what we do and how we do it, and learn about what happens, what doesn't happen. You know, we're looking for partnerships. We're not looking for pity. You know what, as you said, Indigenous people are resilient, but you know what, it's hard to be resilient when most of the systems are designed to put you down. So we need to change that and move together. I mean, that's just, I mean, it takes time, but it takes effort and it takes leadership. That's the best I can say.
Thank you. Myrle?
Yeah, I think after all this, after the second wave, and I'm hoping we don't go into a third wave, but I think we need to revisit what happened and revisit what was going on and the lessons learned. For example, when there were those roadblocks, what did they mean? What do you mean by what is being accomplished when you do that? But when you still have to allow people to go out to get their groceries and then block again. And then not allowing people to go into the community, like at the self-isolation of, you know, a group of people that are social people to begin with, they like to socialize. And the stats that I presented during the summer there, when First Nation Manitoba cases, there was 0, and then the big spike during the winter, what happens? These are the things that need to be revisited, you know, drawing from them lessons learned. When during the summer we were on the land, and during the winter we can't be outside as much. So there's a lot of parallels there that need to be visited, you know, and we need to go back and re-examine what we did right, what was done wrong, and the policies that were imposed, the physical distancing that goes against our cultural beliefs, the way we practice visiting, getting together, and being niches.
Thank you. And thank you to everyone. I'd like to start the closing now, if I may. And I'd like to start by recognizing we had many helpers on this particular broadcast. In particular, I'd like to thank all the panelists who've taken part, and to all the participants that have been there. It's very important that we continue to share the knowledge that you've received here, because of the impact of COVID on our community. It's going to take all of us working together to start to make some changes. In addition to that, I'd like to recognize that we've had some staff members of the National Collaborating Center for Indigenous Health who've been very helpful on keeping this whole process going. So I'd like to recognize Kelsey Desjardins, Roberta Stout, Stephen Hardy, and Donna Atkinson, who have been instrumental in having this broadcast come to you. And I'd like now to invite Elder Barb Hulme to give a closing prayer, after which our Zoomcast will be over.
Thank you, Don. At this time, I would like to remember all who have lost friends and family during this time frame, and just to acknowledge that they will continue to be in our thoughts. Creator, I thank you for this day, this opportunity to share and hear the words and wisdom of all who spoke today. And I ask that the words and thoughts assist all of us as we go about our work and within our daily lives. I ask that we continue to respect each other, to lift each other up as we move through these unfamiliar times and into the future. I ask that we think of our future generations as we are caretakers of the earth, and that we, each in our own way, provide support to those within our circles and our country as a whole. And in the words of Dr. Bonnie Henry, for all of us to be safe, be kind, and be calm in all you do. Thank you.